Great. Welcome back, and welcome our speaker, two speakers, Dr. Delgado and Dr. Powe. Dr. Delgado is Associate Professor of Medicine with San Francisco VA Health System and the UCSF. She's the Director of the Dialysis Program at San Francisco VA, and she also the Chair of the Diversity and Inclusion Committee for the American Society of Nephrology and co-chair of the NKF ASN Task Force on Reassessing Inclusion of Race in Diagnosis Kidney Disease. And her research focus is on functional status, body composition, quality of life, and related outcome among individuals with chronic kidney disease. Dr. Powe served as the leader of the University of California, San Francisco Medical Service at Priscilla Chan and Mark Zuckerberg San Francisco General Hospital, a leading medical department in public hospital and strong basic clinical and health service research program focused on major disease affecting diverse patients locally, nationally, and globally. His interest in improved diversity, discovery, education, and clinical practice medicine, making academic organization function better, enhance scholarship and multidiscipline collaboration. And welcome, Dr. Powe and Dr. Delgado.
Thank you for having us. We are delighted to be able to present at today's forum. Next slide. Before we start, we want to make sure that we say that our opinions expressed are our own and not those of the NKF ASN Task Force to reassess the inclusion of race and in diagnosing kidney diseases. Next slide. This is an outline of how we're going to be constructing our talk today. We're going to go over the NKF ASN Task Force and its goals, the racial disparities in chronic kidney disease, the relation of race with creatinine body composition and GFR, consequences of possible approaches to changes in eGFR measurement. Next slide. So just to review what the charges, we established the task force to reassess inclusion of race in diagnosing kidney diseases in July of 2020. Hit next, please. And we wanted to go over our charge. Charge was examining the inclusion of race and the estimation of GFR and associated implications. Next. To consider the multiple social and clinical implications, be based on rigorous science, and be part of the national conversation. Next, incorporating concerns of patients and the public, especially in marginalized and disadvantaged communities. Next, working towards an unbiased approach to assessment of kidney function to ensure equity. Next, identify any potential long-term implications of removing race from the eGFR formula. Next. And with those charges in mind, this is the task force. Several key stakeholder domains are represented by the members of the task force, including national policy, pharmacology, clinical chemistry, and social science. Next. And the expert panel topics that are being covered include eGFR and measurement, race, racism and genetic ancestry, guidelines and standardization, patient safety with patient perspective and shared decision making, approaches to address race in the equation, clinical consequences of different approaches, systemic and societal consequences of different approaches. Next slide. And as you might imagine, this approach requires a balance, given the complexities and the far-reaching implications of the decision, and balanced against the patient experience and safety in mind. And with that, I will hand off to my colleague, Neil Powe.
Well, thank you, Dr. Delgado. Next slide. I'd like to say that Black kidney function matters. Why? Because kidney failure is up to 3 times greater in African Americans compared to whites. And it occurs on average about 5 years earlier in life. That likens it to what we have seen in terms of young Black Americans whose lives are cut short by violence. And you can see that for the other ethnic minorities, there also is a higher incidence of end-stage kidney failure as well. And it also occurs earlier in Native Americans, Asians, and Hispanics. Next slide. Now, what we know is that actually at earlier in age, on average, African Americans have around the same prevalence of chronic kidney disease as whites. But what we've learned is that with age, they have a sharper decline that occurs earlier in age than white Americans, as shown in the solid line here of Blacks compared to whites. So what we believe is that African Americans have an accelerated progression to ESRD. And that's one of the reasons that they have a higher incidence of kidney failure. Next slide. And we also know that ethnic minorities versus whites are less likely to see a nephrologist prior to dialysis. They're less likely to be treated with home dialysis. They're less likely to be waitlisted and transplanted. And they're less likely to receive live kidney transplants, although that may be improving over the last several years. Next slide. So what causes these disparities? Well, there are a variety of factors that I call drivers that conspire, often with different contributions. And they're shown on this slide. They include biology. We all know the ApoL1 gene that is much more, its 2 variants are much more popular and prevalent in African Americans. The environment, socioeconomic status, behavior and lifestyle, for example, diet, care delivery, access to and quality of care. And then last but not least, clinical and health policies can be drivers. Next slide. And what we're trying to do is to achieve health equity and justice by focusing upstream on drivers, tailoring interventions to the needs of our patients, and trying to implement a palette of tools to eliminate these healthcare disparities. Next slide. Now, I want to make it clear that racism can be a part of the drivers. And this is a paper which Kamara Jones, a noted social scientist, her conception of racism occurring at different levels. So in the environment as a driver, we can have internalized racism. In care delivery, we can have personally mediated racism. And in clinical and health policies, we can have structural or institutional racism. Next slide. So this is what we have been using in the community to estimate glomerular filtration rate from creatinine, what's called the CKD epi-collaboration formula, and the modification of diet in renal disease study equation. And you can see that both have 4 variables that include serum creatinine, age, sex, as well as African American status. Next. Now these equations have been incorporated into clinical practice guidelines in KDIGO in 2013, and they have standardized the assessment of kidney disease around the country. And I'll show you a little bit about that later. But the problem is, or at least the conundrum that we're in next, is that many believe that these equations, by the inclusion of the African American coefficient, that this means we are practicing race-based medicine. Or is it evidence-based medicine, because evidence drove the derivation of these equations? Next slide. So there are over 280 million creatinines performed each year in the US. And this is from the College of American Pathologists Chemistry Laboratory survey. And you can see on the left-hand side of the slide, although the MDRD equation was published in 1999, it wasn't until 2007 that 50% of facilities in the United States were reporting EGFR, and 90% in 2013. And on the right-hand side, you see the equations that have been that are being used. Even though the CKD-EPI equation has been around since 2009, the MDRD is actually more prevalent in practice. So what this illustrates is that when we make a change or information is published, it takes a long time for uptake in the community, as illustrated by this, even with clinical practice guidelines in effect. Next. So I want to talk about the science and the activism that got us here. Next. Next. And I'd like to think that the future holds this quote by Martin Luther King, that the arc of the moral universe is long, but it bends toward justice. Next. So here's a timeline of milestones in EGFR as well as healthcare disparities in kidney disease for African Americans. In 1976, the Cockcroft-Gault equation was developed in 249 white men and extrapolated to women and other ethnic minorities. In 1982, in the New England Journal of Medicine was the first report of African American disparities in ESRD that I just showed you in a prior slide. In 1988 to 1998, there were numerous reports that showed that there were African American disparities in waitlisting and nephrology referral. And in 1999, the MDRD equation was published, the first equation with race, because it had a steady population that had inclusion of women and blacks. I told you that in 2007 we achieved 50% penetration of EGFR reporting in U.S. laboratories, and in 2009 the CKD-EPI equation was published, also with an inclusive population. In 2012, there was another equation called the CKD-EPI serum creatinine and serum cystatin C combined equation. In 2013, we achieved 90% penetration of EGFR reporting in laboratories, and we had these equations incorporated in the clinical practice guidelines. In 2017, we heard the first calls for removal of race from EGFR reporting. And now, in this year, I would say more than approximately a dozen institutions have now removed race from EGFR reporting. Next. So what are the arguments or claims that are being made about use of race in clinical algorithms? Well, it's said that race is a social construct that does not reflect biological function, that incorporation of race caused disparities, that using race institutionalizes racism, that displaying race makes clinicians feel that they are applying race in an unfair way, that race is difficult to obtain and ascertain, particularly if the provider is assigning the race rather than the patient assigning the race. Interracial ethnicity, children are increasing. Patients are reluctant to divulge race to protect privacy. And finally, that EGFR is biological, therefore, race should not be used to estimate GFR. So we're going to explore particularly the biologic basis for this, and I'm going to turn it back over to Dr. Delgado.
Sorry, Dr. Delgado, we cannot hear you
Dr.
yet.
Delgado, I believe you're on mute. Sorry, I'll pull the slides back up. And Dr. Powe, if you could just mute in the meantime, thank you.
Okay, I'm on. Okay. Okay, so here's a little bit of the science behind some of the controversies that we face. Now, 95% of creatine pool is stored in skeletal muscle, and creatine is converted to creatinine at a steady rate of about 2% in the healthy body with healthy kidney function. And daily excretion rate has been used as a metric of whole body creatinine pool. Assumptions of non-renal elimination are usually minimal with gut and liver elimination. Next slide. But we do know that there's variability in influencing, there's variability in serum creatinine measures by a few factors, including aging, inflammation and sepsis, kidney disease, and high-level physical activity. Next. With that being said, in a study of over 18,000 individuals, Kamara, Jones, and colleagues demonstrated that there is a difference in serum creatinine measurement between Hispanic Blacks and non-Hispanic whites. These differences, as you can see, go across multiple age categories, and although it's more pronounced in men, there is still a statistically significant difference among women. Next slide. Now, in their paper, they summarized what we think is the most quintessential part of our current work. Mean serum creatinine values are high in men, non-Hispanic Blacks, and older persons are lower in Mexican Americans. In the absence of information on glomerular filtration rate or lean body mass, it is not clear to what extent the variability by sex, ethnicity, and age reflects normal physiologic differences rather than the presence of kidney disease. And until this information is known, the use of a single cut point to define elevated serum creatinine values may be misleading. Next slide. And indeed, we cannot make any presumptions about serum creatinine values even within the African American community. These two studies by Miriam Udler and Carmen Peralta show that even with genetic African ancestry, there is variation in serum creatinine measurement across the spectrum of different individuals depending on their African ancestry. Which brings us to the next slide. When we think about the issue at hand, you cannot remove the subjective, which is the social customs and behavioral aspects, diet, and other contributions to differences in serum creatinine value from the genetic ancestry, which may be dictating differences in muscle mass, tubular secretion of serum creatinine, and extrarenal elimination. Next slide. So if we're thinking about this, what would muscle mass adjustment correct for if we were thinking that muscle mass is the main driver of differences of serum creatinine? Current creatinine-based EGFR equations don't address differences in muscle mass, and differences by race are related, may be related by muscle mass as presumed by the previous studies we just showed. Next slide. However, when you look at the most commonly used equations for kidney function estimation, hit next please, you'll notice that only the Krakow-Gault equation derived in 1976 that utilized a homogeneous population of 249 men has a metric for body composition using body weight. And the MDRD study equations and the CKD epi equation neither have any kind of a adjustment for body composition. Now we're going to go over the data with that on that next. Next slide. Now, with regard to the performance of the CKD epi equation with and without specification for African American race and with and without height and weight, study investigators did look at whether or not a bias was introduced or whether or not there was a change in the accuracy of the EGFR equation by CKD epi by eliminating the race coefficient in the equation and then evaluating whether height and weight added back in would make a change. Hit next. And as you can see, when you remove race from the all equation on the left, on the right, you'll see that there is a statistically significant difference amongst African Americans such that the estimation against measured kidney function is underestimating kidney function in African Americans using the equation. Next. And when you further remove race and replace race with height and weight, this bias is not changed. The systemic error and the underestimation of kidney function among African Americans still remains. Hit next, please. Conversely, amongst non-African Americans, the opposite is true, and there is an overestimation of kidney function by the EGFR equation when compared to measured GFR. Next slide. Now, within the CKD derivation equation, where they used age, sex, race, diabetes, transplant, BMI, and weight in their original equation development, they did evaluate whether BMI or weight substantively changed the CKD epi equations under investigation. Next slide. Hit next, please. And as you can see, the bias, there was no bias introduced with BMI. There's no change in the equation bias for equation 1 and 2 for BMI categories of 20 to 25, 25 to 30 or greater than 30. There is a bias that's introduced in individuals with a BMI less than 20, but still the CKD epi equation performed better than the MDRD equation. And it certainly doesn't look like there's any evidence for inclusion of BMI based on this work. Next slide. So is it body weight or muscle mass that would be important to consider when we're thinking about estimating equations for kidney function and serum creatinine? And how would we assess muscle mass practically? Next. Certainly, I can impress upon you with this slide that BMI differences may not be obvious when you're looking at just a number. On the left, you have a very muscular guy, and on the right, you have a not so muscular guy, both who have the same BMI. So I'm hoping that with this one image, I can impress upon you that BMI may not actually be the right thing to be using when you're trying to assess the relationship of muscle mass with serum creatinine. Next. And indeed, body composition is a little more complex than body weight or BMI alone. As you can see, our bodies are actually broken up into separate compartments: body fat, skeletal muscle mass, organs, water, and bone. Lean body mass encompasses water, organs, and skeletal muscle. Fat-free mass encompasses everything except body fat. Hit next. And when you're thinking of in the setting of chronic disease, you have to consider the fact that in cases such as CKD and heart failure, water mass actually becomes greater and skeletal muscle mass becomes smaller. Definitely something that you will not capture in lean body mass assessments or BMI assessments. Next slide. So going over what methods we might consider using to assess body composition, there have been several methods, including visual signs and anthropometry. That's where you take a caliper and actually do the pinch test to see, and you look at the circumference of the person's arms and legs to kind of assess what their body mass is like. Turns out that these two methods are actually not that precise, and they cannot be produced from one person to the next. Next slide. And with regards to more sophisticated methods for measurements, such as DEXA scanning, CT scan of the body, and MRI, both DEXA scan and CT scanning do have the risk of issues related to hydration status. Now, remember in the previous image I showed you, that hydration status is linked to muscle mass, and that is a very difficult thing to tease out on radiologic study. Next slide. Now, with regards to, we cannot forget that, like we said, serum creatinine is a marker of creatine breakdown and generation in the muscle. And so it does make sense to think about urine creatinine excretion and serum creatinine as a marker of muscle mass. But to do these sorts of studies to actually pin down how much muscle mass in the general population you may find is a very tedious thing to do, and certainly will be subject to all of the issues that we said that contribute to variability, such as age, presence of CKD and other chronic diseases, and excess physical activity. Next slide. Now, these newer methods, the bioimpedance spectroscopy and multi-frequency BIS, bioimpedance spectroscopy, excuse me, it's late in the day, have also been used to estimate body composition. And it turns out that BIS is actually, when used in the multi-frequency mode, is a very good method for disseminating between muscle mass, fat mass, and extracellular water. And in fact, there have been studies that have shown that BIS is superior to BIA in determining whether changes in muscle mass have occurred in patients with chronic kidney disease. Next slide. But still, we still remain with the same question. Creatinine is a marker of muscle mass. Next slide. But are additional muscle mass adjustments really needed for eGFR? Next slide. Now, certainly you can see with all these different bodies, you might presume that you would need such an adjustment. But in actuality, studies, next slide, have actually not been conclusive in that regard. These studies were conducted by our Italian colleagues, led primarily mostly by Giuseppe Bonfi, where they examined the use of creatinine-based estimates of glomerular filtration rate among athletes. They compared 76 professional male cyclists, 71 amateur cyclists, and 65 healthy sedentary match controls. Next, and found that there isn't a significant difference, really, between serum creatinine, as you can see on the left panel, and the 4-variable MDRD-derived eGFR equation on the right. Now, some might argue that this study may be a little bit flawed, as the participants of the study are of a homogeneous race background. And of course, cycling does not bulk muscle. It actually contributes more to lean body mass. Nevertheless, next slide, when you even look at other athletes, as this group has done, you still see that the difference in serum creatinine compared to controls who are not active isn't substantially different, and they're both intermixed within the category of 1 milligram per deciliter of serum creatinine. Next slide. Now, I hope we've been able to get through this journey, and I hope we're on the same page with regards to a few things. Body weight and BMI may not be the most appropriate in terms of assessing their role in eGFR equations or even a role in differences with serum creatinine. Defining and standardizing muscle mass will be important if we do decide that there is an important role for body composition. Among athletes, at the very least, there is a need for muscle mass. There's not really a clear evidence for the need for muscle mass correction, although more studies are needed to expand on that question. And the clinical approach to assess muscle mass must be standardized before we even get any further with generalizing this sort of approach across the country. Next slide. Now, moving on to the question of whether muscle mass or body composition is a better predictor of creatinine clearance, serum creatinine measures, or kidney function estimation. Andy Rule used 664 random sample of Minnesotans who were non-Hispanic white and asked the question as to whether muscle mass gave a better result for estimating the risk of chronic kidney disease when compared to equations that use demographics. So what he did is he measured serum creatinine and the 24-hour urine creatinine among the whole 664 individuals, and then completed DEXA scanning on all those individuals. He used the equations on the right. One was adjusted just for muscle, the other adjusted for age and sex, and the third adjusted for age and muscle, and found the following. Next. He found that muscle mass was actually a better predictor by itself or with age of chronic kidney disease. And that is along the bottom line of this diagram. Next, but what about whether or not the relationship with body composition is related to serum creatinine? This study perhaps was very futuristic since it was published quite some time ago and is so pertinent to our discussions now. Looked at 3,900 prevalent dialysis patients who were over the age of 18 and asked the question as to whether or not body composition itself would remove the association of serum creatinine being higher in Blacks when compared to non-Blacks. So they did a linear regression, stratifying individuals by Black and non-Black. They measured markers of inflammation, markers of nutrition. Body composition was included. Next slide. Next. And they found that even after adjusting for markers of nutrition, markers of inflammation, diabetes, and markers of body composition, Blacks still had a higher serum creatinine value when compared to non-Blacks. Next slide. So muscle mass may have a role as a coefficient in EGFR. I just don't think that the data out there is still clear enough for us to have that discussion, further discussion. But muscle mass may not necessarily be linked to race differences, as the last study demonstrated that even after adjusting for body composition, race still had a strong association with serum creatinine. And I'm going to defer over to my colleague, Dr. Powe, for the rest of this, for the next section of this talk.
So thank you, Dr. Delgado. So as you can see, from the evidence that she presented, that the relation between race, creatinine, GFR, and body composition is very complex. And that leaves us kind of in what do we do considering this data? And the conundrum that we're in. Next slide. And, you know, I think that removing race from EGFR equations is a worthy aspiration. But I think we also need to have a replacement that is accurate, equitable, and consistent and standardized across the US. And so what I want to go through with you is some of the approaches that might or in fact are being used and the challenges with some of those approaches. Next. And I'm going to concentrate on these approaches in the green box. Next. So one of the ways we could do this is to return, what I call return to the raceless past. We could go back to using just serum creatinine level That doesn't incorporate race, but it's less accurate because it doesn't take into account any factors or proxies affecting creatinine production or secretion. Another way is we could use the Krakow-Gaut equation that I mentioned that does not incorporate race. But the problem with it is that it did not include a diverse population. And it actually overestimates GFR in obesity. And we know how obesity has changed since the development of Krakow-Gaut in the United States. And it's less accurate due to poor precision and bias. So next. So what other approaches could we use? Well, we could go out and directly measure clearance or GFR. And these are raceless approaches too. So we could go back, we could use creatinine clearance and collect 24-hour urines. That doesn't incorporate race in estimation or reporting, but it's less accurate than measured GFR. It certainly takes more time and effort. And I don't have to tell you about the low fidelity with 24-hour, trying to get complete 24-hour urine collections. Well, another way is why don't we just measure GFR directly with filtration markers such as iothalamate or iohexol? Well, that doesn't incorporate race, but as we know, that takes more time, effort, and cost. Next. However, these methods may be useful when decision-making could affect patient health and time permits to obtain these measurements. Next. So the next approach is what I call the dominant race standard. And I say that because what is being done here is discarding the race coefficient from equation and reporting the non-Black estimate for everyone. And yes, this does remove race in reporting, but it's probably discriminatory because it ignores the data on Blacks from studies included in equation derivation. Studies like the African American study of kidney disease funded by the National Institutes of Health. And it's less likely accurate for Blacks. Next. So doing this, I would submit, institutionalizes the exclusion of Blacks from research for clinical decision-making. After many years, we have tried to increase diversity in our clinical trials and clinical data so that the data we see from patients in research can be applied to the patients we see in practice. Next. Now, I want to show you what the issue is and the consequences of removing the race coefficient. Removing the race coefficient and assigning the majority population coefficient results in an increase in persons with CKD and more severe stages. So the question is, in the past, were we underdiagnosing kidney disease in African Americans, or now with a change to this approach, overdiagnosing? Well, you have to look at what the benefit and harms of this. On the benefit side would be that it might affect earlier referral to specialists and earlier access to the transplant waiting list, as well as to some other Medicare services such as nutrition therapy or CKD education. And it might enhance providers' engagement in more end patients in more aggressive CKD management. But on the other hand, it could have deleterious effects. That is, not allowing African Americans who would have normal kidney function to donate kidneys to a loved one. And as we all know, because the use or dosing of many drugs is dictated by kidney function, could affect underdosing of important or non-use of important drugs, as well as contrast imaging procedures. And it could also affect access of patients to clinical trials or lead to anxiety because of labeling from an overdiagnosis. Next. There are other consequences at a higher level. The regulatory approval of drugs. and pharmacokinetics takes into account, in many cases, GFR measurement. And we've been tracking kidney disease consistently in the population by the CDC and the NIH to look at trends in kidney disease prevalence and incidence. Changing a measure would change the incidence and prevalence. And is that really a real change in disease, or is it just a change in measurement? Labeling could lead to decreased access to life insurance. And as I said, research study participation by African Americans. Next. So another approach that has been employed is to use the estimates that are derived from the MDRD and CKD-EPI equations and substitute the label of low muscle mass and high muscle mass for non-Black and Blacks. So this removes race in reporting, but it recognizes the participation of Blacks in derivation studies because it's not like throwing away the coefficient. But it assumes race is a proxy for muscle mass, thereby stereotyping all Blacks as having high muscle mass. And as Dr. Delgado said, it assumes that we can measure muscle mass in clinical practice, and it's less likely accurate for Blacks. Next. So this institutionalizes stereotyping by applying such labels in clinical laboratory reports. Next. So there's another way we could do this, and we could go back to the individuals who created the equations, and we could say, let's develop a new equation, and a new equation that would be raceless, but that would report out one value. And we could weight the African Americans and the other ethnicities in such an equation so that we had a blended equation. Well, this would remove race in reporting, and it also recognizes the participation of Blacks in the derivation studies. But it requires agreement on the appropriate weights. Should it be 13% of the population of Blacks in the US, or the percentage of Blacks at your institution? And it raises the question whether the same should be done for all race and ethnic groups, because there were some differences in CKD-EPI that were detected for Asians and for Hispanics and Native Americans. And it's less likely accurate for everyone. Next. Well, what about this, the raceless range reporting? And this has been done actually by a couple institutions. I just learned today that NYU Langen has taken this approach, is to report two values currently generated by the CKD-EPI equation, but not openly tag them with race descriptors. So that removes race in reporting, and it recognizes the participation of Blacks in derivation studies. But the underlying race distinction does, in the data, remain below the surface. And it leaves clinical correlation, nephrology consultation, and shared decision-making to ordering physicians, not unlike what we do in everyday clinical practice, because our measurements just aren't that precise, including GFR. Next. So, what about this approach, using new raceless markers? So instead of using creatinine, let's use markers like cystatin C that do not incorporate race in estimation or reporting. These are higher costs now. Cystatin is about 10 times the cost of a creatinine, and they're not widely available throughout the United States in all institutions, and often a send-out test that takes some time to get back. And standardization wasn't good in the past, but it actually is improving today. But one thing we know is that a lot of the studies were done in ambulatory patients with cystatin, and it's uncertain what the performance cystatin will be in very ill patients, particularly hospitalized patients, because cystatin C is an acute phase reactant. Next. But maybe this approach, like using measured GFR, we use this when decision-making could affect patient health as an add-on test to creatinine measurements. Next. So I'm going to turn it back over to Dr. Delgado to sum up what we've tried to present today.
So it's been a pleasure to present to you all today. Just to summarize our discussion points, I want to tell you that elimination of race is a worthy aspiration, but without a robust replacement, consequences are far-reaching. And making changes is not a trivial task for anyone or the nephrology, the NKF and ASN task force. Avoid doing more harm than good, which is a philosophy we should all be adhering to. The role of genetic ancestry and differences in serum creatinine needs further investigation and refinement. And the need for muscle mass adjustment in estimating equations remains inconclusive, but studies do suggest that muscle mass may not be linked to racial differences in serum creatinine. Some approaches promulgated to remove race institutionalize discrimination or may be racist. Newer raceless estimation markers may offer a path forward, but need to be scaled and widely adopted and monitored. Solutions should be consistent, durable, evidence-based, and devised with input of clinicians, system leaders, social scientists, and most importantly, the patient. Next slide. And before we end, we do want to emphasize one thing. While we are focused on discussing eGFR equations, hit next, we don't want to lose our focus here. The focus of all our work and our efforts should be looking at drivers of disparity and finding ways to disseminate, to abolish these disparities on race, gender, and sex. And with that, next slide, we'd like to thank you for inviting us to give this talk today.
Thank you so much, Dr. Powe and Dr. Delgado. I think there's a couple questions in the chat box. Dr. Mark Rakowski was saying NHACE shows a similar prevalence of eGFR less than 60 to eGFR creatinine, including back race adjustment. Trends in the prevalence, that's his comment. Let's see, there's another question. Kevin Fowler asked Dr. Powe, is the accelerated increase in eGFR progression in African American caused by the 5 drivers of disparity? Is there one aspect that has a greater impact on acceleration?
Right. So I would say that we don't know the answer to that. And that has been, a subject of vigorous investigation. I would say this. I don't think it's all biological. Many people have said, well, that's APOL1. The APOL1, the 2-variant mutation of the APOL1 is only present in about 13% of African Americans. And if you look even at people who have 1 allele or 2 alleles, the variability in disease progression varies from people who have little acceleration to people who have lots of acceleration. So there's probably a second hit. So what are those other, not everybody has it in the African American population, and not everybody who has the APOL1 allele progresses. So it must mean there's second hits here. And the other drivers that I mentioned, whether it has to do with socioeconomic status, whether it has to do with behavior, whether it has to do with our care delivery, and I think a lot of it may be that is access to care, and having a regular primary care physician, or who is going to recognize that you have kidney disease and make sure that you are on the right medication, whether it's ACE or ARBs, and avoidance of nephrotoxins. Okay, so we don't know. We don't know the contribution. They probably all contribute in some way. but there's no one magic bullet. And if you layer that on top of the different causes, whether it's hypertensive nephropathy or diabetic nephropathy, they could be the drivers of each of those could be very different as well.
Sochi has a question. She said, an incredible complex topic. Thanks for walking us through it. Are there specific instances? Exactly, that's what I tried to ask. Transplant listing, when we should abandon the race suggests already so, as to be most careful about minimize disparity. I was thinking about maybe for the transplant, we should all do an iothalamate study for when they approach EGFR of 20.
So there have been several discussions about abolishing the race for transplant evaluation. Some folks are advocating to actually start at an earlier EGFR rather than using the cutoff, or perhaps even looking at the rate of decline rather than looking at an EGFR cutoff of 20, especially if we think that there is somewhat of an accelerated loss of kidney function for certain individual groups. I think at this point, that's under discussion, and we're evaluating all that work. It's very tedious at this point to think about it. First, we need to hammer down whether or not, what the right path would be to start with in the general population, and then hammer down to the transplant community.
Yeah, I would also add to this. There was a recent study published at Partners that looked at, if you remove the race coefficient, how many people would move across EGFR 20 and potentially be waitlisted. And they showed that about 3% of patients would do that. And none of them actually got transplant. So one might conclude, okay, that the equation's bothering. But they also looked at a larger group of patients who already had EGFR less than 20. And 80% of the African Americans were not waitlisted, evaluated, or transplant. What does that tell you? It says that there are larger drivers than the equation that are affecting access to kidney transplantation. And I think that was the point of Dr. Delgado's last slide, that if we're so focused on the equation, are we missing the boat? Are we not focused on the true drivers of disparities? And what if we put all of our attention to discovering those other things, which could be racism too, okay? Would we make more progress than focusing on the equations?
Right, bravo. Dr. Bessarab has a question. China has developed their country-specific EGFR, I was told.
Actually, there are a couple of other countries, including Japan, that have a separate EGFR equation that correct for differences in their patient population. For me as a researcher in body composition, it makes me question whether or not that's based on differences in muscle mass or differences in the excretion of creatinine. So far, there's not a lot of data to support either one in the US. There are studies that are undergoing right now, and I am privy to one that has some promise in showing that serum creatinine measurement and differences by serum creatinine and EGFR may not necessarily be driven by body composition.
Great. My question is, if cystatin C is more widely available, it's more affordable, do you think we should use CKD epi cystatin C instead of CKD epi creatinine?
I would say yes, if it's more widely available, with one caveat. We have studied creatinine for almost 50 years. We have only studied cystatin C for about 15 years. So we know a lot more about creatinine than we know about cystatin C. I suspect as we study it more, we will find out more. We will find out whether it is a better marker, not just for rates, but just for estimation because of this issue that it's an acute phase reactant. So we need to be a little cautious although I think that is a good path to a raceless future. But there also are other markers now being developed as well, in addition to cystatin C, that is really the frontier of GFR measurement. They're not here yet, but it's great to have that aspiration.
And to Dr. Powe's point, the cystatin C measurement is not without its imperfections across the spectrum of body composition. And so we do need to take that into account when you are using that as a measurement, that there are some imperfections, although not as profound as with the use of serum creatinine, but there are some differences at the extremes of body composition and body weight.
I'd like to just add something. The issue is we now have institutions doing this in different ways. And we know that our patients cross institutions. So if patients are told in one system that they have chronic kidney disease or a certain severity of kidney disease, and they go to have care in another system, and they're told something else about their kidney function, that can't be good. That's just chaos, to not have standardized measurement. And what we now have is a panoply of organizations making decisions, not in a unified or uniform manner. And I think that is likely to cause harm to patients who travel across institutions, let alone confusion by healthcare professionals who also work across different institutions.
Right. Now, one thing we can do at this point is make sure everybody has risk factors, has urine protein, urine albumin measured. That would definitely eliminate falsely underestimate the kidney function and for referral patient to the right time and putting on the right medication.
I would add to that, as a practicing nephrologist, oftentimes we hang on the eGFR number, and patients are sort of trained that if it changes from one number to the next, from 14 to 15, or if it goes down one day from 15 to 9, that suddenly there's something major going on, or if it gets a little bit better, that their trajectory may not be what you think it was. And I think that's an opportunity for the clinician to start maybe expanding the horizons of the individual a little bit more and bringing them in to have this patient-physician dialogue, a relationship where you actually come to a common understanding of how the other markers of on chemistry also contribute to what we think might be happening in the individual. Oftentimes it only takes a few minutes to talk about the blood urea nitrogen, the change in, hemoglobin drop, phosphorus management, the PTH, all of those are markers of CKD progression. So rather than pointing to just one number and saying, you're getting worse or you're getting better, I think we can do a better job of educating our patients and bringing them along with the storyline and really getting them engaged in understanding why or how we're thinking about how we're managing them on one day to the next.
Great. Thank you so much. What a fascinating talk. Thank you both.
Well, thank you for having us. We appreciate that. We think it's important to let those in the community know what we're doing on the task force. And we're going through a lot of complex data and hearing from a lot of different voices on this, terribly important subject. So. Yeah,
and thank you both for being the co-chair on the task force. It's really very important work and a lot of work, I know.
Well, and also hearing those stories from the presenters from the talk before, the patient stories, you guys are the reason why we're doing this. We really want you to know that we care, and all the time and effort we're putting into this is because we want to make life better for you. And I have to tell you, those stories almost made me cry when I was listening to them.
It is. Yeah. Patients are the reason we're doing this.
That's right.
Right. Right. Not our own feelings, or, we really have to keep the patient at best interest at the center of this.
Exactly.
That's right.
Exactly. Well, again, thank you so much. If you can stick around, look at the chat. There's some excellent comments, and if you want to make more, feel free. I think that's the end of our symposium today. I don't know about you. I was so fascinated by this symposium. I learned so much, and I'm so inspired. Especially thank for the committee members. I don't have a list, but every one of us has contributed greatly to this committee, and we meet once a month, sometimes more in between, a lot of emails, and the great appreciation for all the speakers volunteered their time and effort to speak on this. The kidney community is a great community. We are making our patients' life better. That's our mission. And have a good weekend, and hope to see you next year.